Okay, let's unpack this. Take a moment to think about the intricate, unseen world that exists inside the human mouth. It's far more than just, enamel and soft tissue, isn't it?
Oh, absolutely. It's this incredibly vibrant, complex ecosystem, teeming with microbial life, bacteria, fungi, viruses.
Right, and most of these microbes, they just live peacefully with us. They're part of our normal flora.
Exactly. The vast majority are just fine. But scattered among that crowd are certain groups that really demand our attention. They need vigilance because, well, they have the potential to cause some significant harm.
And today we're diving deep into one particular group, a genus of bacteria known as Neisseria.
That's the plan. We're going to take a really close, detailed look at these organisms. We'll explore their fundamental characteristics, what makes them tick physically and biochemically.
And how they actually cause disease, their virulence factors.
Yeah, we'll get into the fascinating ways they manage that. Then we'll look at how we identify them in the lab, which isn't always straightforward depending on where the sample came from.
And crucially, especially for you listening, we're going to examine what all this means, directly and indirectly, for your future practice as a dental student.
Precisely.
And just to be clear, this isn't going to be like reading a textbook out loud. Our mission today, it's specific. We're kind of your expert guides navigating through the source material you've given us.
Right. We're pulling out the key nuggets, the really important bits about Neisseria.
Yeah, and filtering everything through that critical lens of what you specifically need to know as you head into the dental field. We want to get you well-informed, efficiently, maybe with some surprising facts and enough detail so it sticks, all pulled straight from the info we have here.
I think you'll find it relevant. As we'll see, Neisseria has some pretty specific and significant ties to dentistry.
These organisms, they really offer a compelling case study in micro, don't they?
They really do. They show that whole spectrum from being completely harmless, even beneficial residents, all the way to being rapid, severe, sometimes life-threatening pathogens.
Understanding that split, that duality, and the reasons behind it.
Yeah.
That seems like a solid foundation.
Incredibly solid for appreciating the diverse microbial dynamics you're going to encounter every single day in practice, in the mouth and, beyond.
Okay, so roadmap laid out. Let's just jump right in. At its absolute core, what is Neisseria? What are we talking about? Basic classification. What do they look like?
Okay, so at the most fundamental level, the genus Neisseria belongs to a family of bacteria called Neisseriaceae. Simple enough.
Neisseriaceae.
Yeah.
Got it. And under the microscope, gram stain.
When we do a gram stain, they come out as gram-negative. That means they don't hold on to that first crystal violet stain. They pick up the pink or red counter stain, saffronin.
Okay, gram-negative. And their shape, kachi, rods.
They're spherical or oval shaped, so yes, they're kachi. But here's one of their most striking and diagnostically useful characteristics. Their arrangement.
Arrangement? How so?
They almost always show up in pairs. We call that arrangement diplocochi. Diplo for two.
Okay, pairs of kachi.
Diplocochi. But it's not just two round balls stuck together. They have a very distinctive shape within those pairs. The sides that face each other, the adjacent sides, they're flattened.
Flattened. Oh, wait, is this the coffee bean thing?
Exactly. That's the famous description. It gives the pair a shape like two coffee beans side by side with their flat surfaces touching. Or sometimes people say kidney beans. That visual is key.
Oh, yes, the coffee bean shape. That image really sticks. So gram-negative kachi, typically in these coffee bean pairs. Beyond that, look, what about their biochemistry, key traits for identification?
There are two really essential biochemical tests here. First, the oxidase test. All species of Neisseria are universally positive for oxidase.
All of them. Okay, that's a big one.
It is. It's a very rapid, crucial, presumptive test in the lab. Helps narrow things down quickly. The second common trait is that most species also produce the enzyme catalase.
Oxidase positive, usually catalase positive.
Right. So if you find gram-negative diplocochi, they've got that coffee bean look and they test positive for oxidase and probably catalase. Well, you've got a very strong indication that you're dealing with Neisseria.
It's like their visual and chemical fingerprint combined. Now, you mentioned earlier the difference between pathogens and commensals. That seems vital, especially for understanding risk.
Absolutely vital. The source material is very clear here. While the genus has many species, two stand out as the primary significant human pathogens. Those are Neisseria gonorrhea and Neisseria meningitis.
The ones that cause the well-known diseases, gonorrhea and meningitis.
Correct. Those are the big players in terms of causing serious human illness.
And the rest of the Neisseria species, what are they up to?
The others that we commonly encounter, and the source mentions these too, are typically commensals. They just live harmlessly as part of our normal microbial flora.
Where do they usually hang out?
Particularly in the mouth and the upper respiratory tract. Species like Neisseria and Mucosa and Lactamica, they're just part of the usual crowd.
Generally just passengers then, contributing to the overall microbial scene without causing trouble. But the source did mention they can be opportunistic.
Yes, and this is a really important point, especially thinking about oral health. While these commensal species are usually benign, they can become opportunistic pathogens under certain conditions.
Like what kind of conditions?
Well, think about if the host's immune system is weakened, maybe due to illness or certain medications, or if normal barriers get breached, like after an injury or surgery.
So if there's an opening, they might take it.
Exactly. The bacteria that were just harmlessly sitting there might seize the opportunity to invade tissues and actually cause an infection. So even the normal Neisseria in the mouth aren't entirely without risk,
Okay, let's pause here. For you, the dental student listening, why does this foundational stuff, gram stain, shape, the key tests, knowing pathogen versus commensal, why does that matter right now?
It matters hugely because recognizing these organisms is often the very first step in identifying a potential infection. If you're involved in collecting a sample, maybe from a suspicious lesion in the mouth or a throat swab, or looking at a gram stain report,
you need to know what you're looking for.
Precisely. Knowing to look for those gram-negative diplocacci with the coffee bean shape is your initial clue. Understanding the oxidase and catalase tests backs that up. And critically, for your field, knowing that some Neisseria are common, harmless residents of the mouth, while others, like gonorrhea, which can cause oral infections, are known pathogens. That helps you understand the context.
So it's not just seeing the bacteria, it's knowing what it means when you see them there.
Exactly. It helps you interpret results correctly. Is this just normal flora, or is it potentially something problematic? Especially when they might look kind of similar under the scope. It's the bedrock for making informed clinical judgments.
That makes perfect sense. Having the tools for that initial recognition and understanding the local landscape. Let's dig a bit deeper into their structure, their morphology, because there are specific features here that aren't just visual cues. They directly impact how they cause disease and how we find them.
Right. So we've got gram-negative cocci. They're also non-modal, no flagella for moving around. And they don't form spores.
No spores, okay. And that classic diplocacci arrangement with the flattened sides?
Yep. But where we often find them within clinical samples, that's a major diagnostic hint.
Oh, where's that?
A really significant characteristic of the pathogenic Neisseria, especially gonorrhea and meningitis, when you look at smears from an infection site, is that they tend to be found intracellularly.
Intracellularly, meaning inside cells.
Exactly. Frequently located inside host immune cells. Specifically, polymorphonuclear leukocytes, or PMNs, think neutrophils.
So you see them inside the white blood cells on a slide?
Often, yes. If you look at a smear of pus or CSF or inflammatory fluid from an infection, you might see clusters of those coffee bean-shaped diplocaccia packed inside the cytoplasm of a single white blood cell.
So the bacteria are essentially being engulfed, or maybe hiding inside the immune cells?
It's a visual sign of the host's immune response trying to deal with the infection, definitely. But it also shows the bacteria are right there and potentially even surviving within those cells. The source gives that classic example, seeing gonorrhea looking kidney-shaped inside PMNs in urethral discharge.
Right, the gonorrhea example.
Yeah, but the principle is broader. Seeing gram-negative diplocaccia inside white blood cells in a sample from any inflamed site where you might suspect Neisseria, that's a very strong presumptive diagnostic clue. It suggests they're actively causing inflammation.
That intracellular location sounds incredibly distinctive under the microscope. Now, what about protection on the outside? Capsules. We touched on them, but let's elaborate. How does that structural feature impact their ability to cause harm?
Yes, and there's a key difference between the two main pathogens here. Neisseria meningitis is famous for being capsulate. It has this prominent polysaccharide capsule surrounding it.
Polysaccharide capsule.
Okay, and this capsule is critical, especially for the virulent strains. Neisseria gonorrhea, interestingly, does not form a true carbohydrate capsule like that. The source mentions it might have a polyphosphate one, but it lacks that major polysaccharide shield that N. meningitis has.
Why is having that polysaccharide capsule such a big deal for N. meningitis? What does it do?
That capsule is a primary virulence factor because it's strongly antiphagocytic.
Antiphagocytic, meaning against being eaten.
Exactly. It makes it significantly harder for host immune cells, like those PMNs, to effectively engulf and destroy the bacteria. It acts like a shield, a physical and chemical barrier protecting the bacterium.
So it helps them evade the immune system.
Massively. This ability to resist phagocytosis is essential for N. meningitis to survive in the bloodstream and potentially cross into the central nervous system to cause meningitis. It's directly linked to how severe the disease can be.
So one pathogen has a big shield, the other doesn't, and that affects where they can go and the trouble they cause. Okay, let's bring this section back to the dental student. Why focus on knowing about intracellular bacteria and capsules?
Because this morphology directly impacts how you interpret lab findings or understand how an infection progresses. If you're looking at a microscopic image or a report, seeing those coffee bean gram-negative Diplocacci inside white blood cells just screams, "Consider Neisseria." It's a visual trigger for more specific tests.
Right, it points you in a direction.
And understanding the capsule difference helps you appreciate why N. meningitis can cause such widespread systemic disease. It has this built-in defense mechanism that N. gonorrhea generally lacks, or compensates for differently, as we'll see. It connects what you see or read about to the organism's actual potential to cause serious harm and spread.
That link between structure and clinical potential is really powerful. And as you hinted, structure isn't their only weapon. They come equipped with a whole arsenal virulence factors that let them cause disease. Let's really unpack those.
Absolutely. Pathogenicity isn't just about being there. It's about having the right tools. Tools to attach, to invade, to multiply, to evade the host response. And Neisseria, especially the pathogenic ones, have a sophisticated collection of these virulence factors.
What's a key one on their surface they use to interact with us?
The source really highlights pillae, which are also called fimbriae. Think of them as these thin, hair-like appendages sticking out from the bacterial surface. They're made of protein subunits called pillins.
Hair-like. Pilly. Okay. What do they do?
They have two main jobs crucial for infection. First, they help the bacteria make that initial attachment to host cells. You got a stick to start anything. Second, they also help inhibit phagocytosis, a bit like the capsule, making it harder for immune cells to grab onto them.
So like grappling hooks that also make them slippery. But you mentioned something really interesting about these pillae before they can change.
Ah, yes. This is where their immune evasion gets really sophisticated. The pillae can undergo significant variation. The source points to both antigenic variation and phase variation.
Antigenic and phase variation, what does that mean in simple terms?
Antigenic variation means the bacteria can actually change the protein structure of the pilin subunits. They alter the face they show to the immune system. Phase variation means they can switch the expression of pillae completely on or off.
Wait, so they can just change their surface appearance or make the pillae vanish altogether?
Pretty much, yes. Imagine the immune system learns to recognize a specific pilin protein. Through antigenic variation, the bacteria can suddenly swap it for a different one, making the antibodies the host just made useless. And with phase variation, they can just decide, nope, don't need pillae right now, and turn them off.
Wow, that makes it incredibly hard for our immune system to keep up.
Exactly. This constantly shifting target is a major reason why, for example, people can get infected with N. gonorrhea multiple times. The bacteria they encounter next time might have different pillae. The source really drives home how critical these are. It says strains of N. gonorrhea that lack pillae are not pathogenic. They lose their disease-causing ability without them.
That's a remarkable trick for dodging immunity. Okay, we talked about the capsule for N. meningitis. Let's just quickly reinforce its role as a virulence factor.
Right. The polysaccharide capsule on virulent N. meningitis strains, as we said, is primarily antiphagocytic. Protects them from being eaten by phagocytes like neutrophils. This lets them survive and multiply in the bloodstream, which is vital for them to spread and potentially reach the brain.
Makes sense. Now, what about the classic calling card of gram-negative bacteria, endotoxin?
Yes, lipoligosaccharides, or LOS. This molecule is baked into the outer membrane of gram-negative bacteria. In Neisseria, especially N. meningitis, LOS is a powerful trigger for inflammation, and it directly damages blood vessels.
How does it cause damage?
As the bacteria grow and divide, they continuously shed or release LOS into the tissues and bloodstream. This triggers a massive, often excessive inflammatory response from the host. It's this host response to the endotoxin that causes much of the damage, the characteristic vascular injury, the hemorrhagic spots seen in meningococemia.
So it's the body's reaction to LOS that's so dangerous?
Largely, yes. This massive dysregulated inflammation can spiral into severe complications like endotoxin shock and that devastating condition called Waterhouse-Friderichsen syndrome that involves adrenal gland hemorrhage, shock, DIC disseminated intravascular coagulation, basically widespread abnormal clotting that uses up clotting factors, leading to severe bleeding and organ failure. It's bad news.
And gonorrhea has LOS too.
It does. While it doesn't secrete other major toxins, its LOS also contributes significantly to the localized inflammation and tissue damage you see in gonorrhea infections.
So LOS is less like a tool they actively use and more like something that falls off them and causes a huge damaging overreaction in us.
Got it. Any other enzymes they deploy? This sounds relevant for the mouth. Absolutely. And this one is directly relevant to mucosal surfaces like the oral cavity, pathogenic Neisseria, and actually other bacteria that colonize mucous membranes like Haemophilus influenza and Streptococcus pneumonia. They produce an enzyme called IgA1 protease.
IgA1 protease. IgA is that key antibody on mucosal surfaces, right? In saliva, mucus.
Exactly. IgA, specifically the IgA1 subclass, is our primary antibody defender on those surfaces. It's there to block pathogens from getting a foothold. This enzyme, IgA1 protease, specifically targets and breaks down IgA1.
So they have scissors specifically designed to cut up our first line of antibody defense on those surfaces.
That's a perfect analogy. The protease cleaves the IgA1 molecule right at a specific point in its structure, effectively inactivating it. It can no longer do its job of clumping bacteria together or stopping them from attaching to our cells.
And why does that matter so much?
By disabling IgA1, the bacteria dramatically improve their chances of colonizing and sticking around on mucosal surfaces. It makes the IgA1 protease a critical virulence factor for any organism trying to set up shop in places like the pharynx, and very relevantly for you, the oral cavity.
That enzyme sounds like a master key for getting onto those mucosal surfaces. Any other sneaky proteins mentioned?
Yes, for Neisseria gonorrhea, the source talks about opacity-associated proteins, or OPA proteins. These are on the outer membrane and act as secondary glue, helping the bacteria stick really firmly to host cells after the initial, maybe weaker attachment by the pili.
Okay, secondary adhesins. Sticking better.
But here's another really fascinating detail from the source. Some of these OPA proteins have the remarkable ability to mediate sticking to polymorphonuclear cells, those very same immune cells, the neutrophils, that are supposed to engulf and destroy them.
They stick to the immune cells. Why on earth would they do that?
It gets even wilder. The source indicates that the sticking to PMNs, helped by certain OPA proteins, can actually allow the Gonococcus to survive after being phagocytosed, after being eaten by these white blood cells.
Survive inside the immune cell.
Yes. Instead of being killed, they can persist inside the phagocyte.
Yeah.
This could offer them a safe haven, a way to evade immediate killing, and maybe even hitch a ride deeper into the host tissues within that immune cell. It's a really sophisticated way to potentially turn a host defense into a survival strategy, or at least stall for time.
Wow, hiding out inside the very cells trying to eliminate them. That is incredible. Okay, one last piece of the arsenal. Resistance to our main weapon, antibiotic.
Right. We have to talk about beta-lactamase. The source points out that some strains of Neisseria gonorrhoeae produce this enzyme.
Beta-lactamase, that breaks down penicillin-type antibiotic.
Exactly. It's a major mechanism of antibiotic resistance. Beta-lactamase enzymes specifically target and break the beta-lactam ring structure, which is the core part of crucial antibiotics like penicillin and ampicillin.
So these strains just chew up the antibiotic before it can hurt them.
That's the gist of it. By making beta-lactamase, these strains become resistant to penicillin. This has hugely complicated treatment and is a major reason why penicillin often isn't the first choice for gonorrhea anymore. It's a clear example of bacteria evolving to fight back against our drugs.
Okay, so let's put this whole impressive, maybe scary arsenal together. We've got the changing pili for sticking and dodging immunity, the capsule shield for N meningitis, the damaging LOS endotoxin causing inflammation, the IgA1 protease cutting up mucosal antibodies, the OPA proteins helping end gonorrhea stick and even survive inside immune cells, and beta-lactamase breaking down antibiotics. It paints a picture of some very well-equipped pathogens.
It really does. It shows their remarkable adaptation to living in humans, especially on mucosal surfaces, and for N meningitis, surviving in the bloodstream. That ability to change surface antigens, the antigenic variation, that makes durable immunity and simple vaccine design really challenging.
And the IgA1 protease.
A perfect example of a targeted attack on a specific host defense system, right where they want to live. And the beta-lactamase resistance. That just highlights this ongoing arms race between bacteria and antibiotics. It demands constant monitoring and new drug development. Understanding these specific mechanisms isn't just academic. It explains why these infections can be so persistent or severe or hard to treat.
So, stepping back again for the dental student listening, why spend time understanding this detailed list of virulence factors? How does it connect to their future work?
Because understanding the how of pathogenesis, the specific tools bacteria use, directly informs your understanding of the why. Why do certain symptoms appear? Why are some infections hard to clear? Knowing about AGA1 protease, for instance, gives crucial context for the immune defenses of the mouth and throat that you'll work with daily. It helps you appreciate how pathogens get established there.
And the resistance part.
Awareness of beta-lactamase is fundamental to understanding antibiotic resistance, which will directly impact your decisions about prescribing antibiotics later on. Understanding how N-gonorrhea's factors cause inflammation helps connect its potential manifestations in the mouth back to its basic biology. This isn't just general micro. It's foundational knowledge for understanding infection in the head and neck region, explaining symptoms, predicting complications, maybe even guiding treatment choices down the line.
It absolutely connects that microscopic world to the actual patient sitting in your chair. Speaking of patients, let's move on to the diseases themselves caused by these pathogenic Neisseria. And let's be really specific about linking them back to potential oral issues and why this is relevant for you as a dental professional.
All right, let's look at the clinical picture described in the source, focusing first on the two main human pathogens, Neisseria gonorrhea and Neisseria meningitis.
Starting with Neisseria gonorrhea, the cause of gonorrhea.
Right. Gonorrhea, a very common sexually transmitted infection. The classic presentations involve the genital tract. In males, acute urethritis, often that painful burning during urination, may be a noticeable purulent discharge. In females, cervicitis, which can actually be asymptomatic sometimes, or might present with vaginal discharge and pain.
But the infection doesn't always stay localized, especially in females. It can spread upwards.
Yes, that's a major concern. In females, the infection can ascend from the cervix into the upper reproductive tract. This can lead to salpingitis, inflammation of the fallopian tubes, potentially causing tubo-ovarian abscesses, and it can all culminate in pelvic inflammatory disease, PID.
And PID can have serious long-term consequences.
Definitely. Scarring and damage to the fallopian tubes from PID can significantly increase the risk of ectopic pregnancy later on, and it's a major cause of infertility. So what starts localized can really impact reproductive health long-term.
Now, crucially, the source highlights infection sites beyond the genital tract, and some of these are highly relevant to dentistry.
Precisely. While it's sexually transmitted, N-gonorrhea can infect other mucosal surfaces through different types of sexual contact. These include the anorectal area, causing proctitis, and significantly for anyone in dentistry, the pharynx. Pharyngeal gonorrhea is a distinct clinical entity, often acquired through orogenital contact.
Pharyngeal gonorrhea. Okay, that's a direct hit for the head and neck area. Can the infection also spread throughout the body, become systemic?
Yes, although it's less common, in a small percentage of cases, N-gonorrhea can escape the initial site and spread through the bloodstream. This leads to disseminated gonococcal infection, or DGI.
And what does DGI look like?
DGI is more severe. It commonly presents as arthritis, often affecting multiple joints, and it can cause characteristic skin lesions, small pustules, or maybe little hemorrhagic spots.
The source also mentions a specific N-gonorrhea infection in newborns, acquired differently.
That's ophthalmia neonatorum. It's a severe acute conjunctivitis, an eye infection, in newborns. It happens when the baby picks up the bacteria from an infected mother during passage through the birth canal.
And that's serious.
Extremely serious. It requires immediate antibiotic treatment to prevent severe complications, including permanent blindness. It really highlights the importance of screening and treating pregnant individuals for STIs.
Okay, let's explicitly make the connection. Gonorrhea and dentistry. How does this common STD relate directly or indirectly to what a dental professional does?
The most direct link is encountering oropharyngeal gonorrhea. Since orogenital contact is a transmission route, N-gonorrhea can set up shop in the throat and mouth.
And what symptoms might that cause? Things a patient might complain about to their dentist.
Exactly. It could present as a sore throat, pharyngitis, maybe tonsillitis, or even a specific type of gingivitis or oral lesion. This means in certain situations, especially when taking a thorough history or examining unusual oral signs, you need to have gonorrhea on your radar as a possible, though maybe less common, cause.
So it emphasizes the need for a good medical history and careful exam. You might be the first one to spot something.
You absolutely might. It highlights that connection.
Okay, awareness of oral gonorrhea is key. Let's switch gears to the other major pathogen, Neisseria meningitis.
Right, and meningitis. This one is often feared as the cause of meningococcal meningitis and meningococemia, the bloodstream infection.
Where does this infection usually start?
Typically, the first step is colonization of the nasopharynx, that area of the upper throat, behind the nose. What's interesting is that quite a few people, a significant percentage of the population actually, can carry N meningitis there completely asymptomatically.
They're just carriers.
Yes, carriers. They can potentially spread the bacteria but don't get sick themselves. However, in someone who is susceptible, the bacteria can invade from the nasopharynx into the bloodstream. That's meningococemia.
And what are the key signs of meningococemia?
Meningococemia is a severe systemic infection. Usually presents with fever, feeling generally unwell, malaise, and a characteristic rash. The hallmark sign is often the appearance of petechia.
Petechiae. Those are the little spots.
Exactly. Yeah. Small, pinpoint, reddish-purple spots that don't blanch, meaning they don't disappear briefly when you press on them. Mm-hmm. They're caused by bleeding into the skin from damaged capillaries due to that bacterial endotoxin, the LOS. Recognizing petechia is critically important because it can be an early warning sign of life-threatening meningococcal disease.
And from the bloodstream, it can then get into the central nervous system.
Correct. From the bloodstream, the bacteria can cross the blood-brain barrier and cause meningitis inflammation of the meninges, those membranes covering the brain and spinal cord.
And meningitis symptoms are?
Often include fever, a really severe headache, stiff neck, neutral rigidity, sensitivity to light, photophobia, confusion, and sometimes that same petechial rash seen in meningococemia can be present.
We talked about the damaging effects of the LOS endotoxin earlier. How does that play out in terms of severity with meningococcal disease?
The LOS release is absolutely central to how rapidly this disease can progress and how severe it gets. It triggers that massive inflammation and vascular damage. This can lead incredibly quickly to shock, widespread clotting problems, DIC, and multi-system organ failure. That's the feared Waterhouse-Friderichsen syndrome we mentioned.
So it can go from bad to catastrophic very quickly.
Incredibly quickly, sometimes just hours. That's why it's such a medical emergency.
Besides meningitis and meningococemia, can N meningitis cause other problems?
Yes, though less commonly. The source mentions other possibilities like pneumonia, septic arthritis, that's a bacterial infection within a joint, and purulent pericarditis, which is infection of the sac around the heart.
Septic arthritis again? Interesting. Okay, so how does N meningitis, primarily known for meningitis, connect to the world of dentistry? It seems less direct than oral gonorrhea.
It's less direct pathogenically in the mouth, yes, but there are still connections. First, the initial colonization site, the nasopharynx, is right there in the upper airway system, directly connected to the oral cavity. Just general awareness of pathogens in that neighborhood is relevant for anyone working in the head and neck.
Okay, anatomical proximity. What else?
Second, and maybe more critical clinically, is the importance of recognizing signs of serious systemic infections during your routine patient assessments. As a dental professional, you're looking closely at patients' faces, necks, maybe even exposed arms or legs sometimes. Spotting those characteristic petechial skin lesions of meningococemia, that could be a crucial, potentially life-saving observation.
He might be the one who flags it.
Absolutely. You're part of the healthcare team. Recognizing signs of serious systemic illness that might just happen to appear during a dental visit is part of that responsibility. It prompts you to refer that patient for immediate medical evaluation. Also, while the source doesn't specifically mention the TMJ regarding septic arthritis from N meningitis, the principle that systemic bacterial infections can affect joints is relevant to structures you deal with.
That's a vital point. Dentists are often on the front lines and observing patients closely. Recognizing systemic signs is key. What about the other Neisseria species and the related organisms in the Neisseriaceae family the source discusses?
Right. The source reminds us that many other Neisseria species like Ensiflava and Mucosa and Sicca are usually non-pathogenic residents. They're part of the normal microbial landscape in the mouth, nasopharynx, pharynx.
Mostly harmless background players, but they can occasionally cause trouble.
Yes. The source notes some of these, like Enflavescens and Moraxella cataralis, which is closely related and sometimes grouped here contextually, have been reported to cause opportunistic infections, including rare cases of meningitis, especially in people who are immunocompromised or have other health issues. It just reinforces that idea. Even normal flora aren't always harmless.
And there was one organism in the same family, Neisseria, mentioned specifically as part of the normal oral flora, but with really significant systemic links. This feels highly important for dentistry.
It is. The source specifically flags Kingella kinga. This bacterium is a recognized member of the normal microbial flora of the mouth and throat, especially common in children, and the source explicitly states its association with serious systemic infections.
Like what?
Including endocarditis, that potentially life-threatening infection of the heart valves, and also infections of bones, joints, and tendons.
Okay, endocarditis is a huge concern in dentistry because of potential bacteremia during procedures, especially in susceptible patients. And bone and joint infections, that's directly relevant to the jaw, TMJ, surrounding structures.
Exactly. This Kingella kingae connection is incredibly significant. While the source, talking about dental abscesses or endodontic infections, emphasizes anaerobes and other commensals rather than specifically Neisseria species as primary causes.
Right. It didn't list Neisseria as the main culprits there.
No, but including Kingella kingae in this family, identifying it as an oral commensal, and linking it clearly to endocarditis and bone joint infections, that strongly reinforces a core concept for dentistry. Bacteria that live normally in the mouth can, in certain situations, get into the bloodstream or spread locally and cause serious infections elsewhere in the body, like the heart, or in adjacent structures like the jawbone or TMJ. Kingella kingae is a perfect example of a normal oral bug with significant systemic potential.
Wow. Okay, so summarizing this whole disease section, specifically for you, the dental student listening, what are the absolute key takeaways?
It's multi-layered. First, be aware, pathogenic Neisseria can directly cause disease in the mouth. Think oropharyngeal gonorrhea showing up as pharyngitis or gingivitis. Second, remember the normally harmless commensal Neisseria can occasionally turn opportunistic. Third, and maybe most critically, understand that related organisms from the same family that are normal residents of the mouth, like Kingella kingae, are strongly linked to serious systemic infections, endocarditis, bone, and joint infections.
And the fourth point?
Your role in patient assessment includes being vigilant for signs of serious systemic infections, like the petechia of meningococcinea, which might present incidentally during a dental visit. It all powerfully illustrates how interconnected oral health and systemic health truly are. The microbial world you work with daily has consequences far beyond the mouth itself.
That interconnectedness is fundamental. So if you encounter something suspicious, maybe potential oral gonorrhea, or you need to identify Kingella from a bone infection sample, how do the labs actually pinpoint the exact culprit? Let's dive into the lab diagnosis methods.
Yeah, accurate lab diagnosis is absolutely essential. You need to confirm the infection, figure out the specific species involved, especially differentiating from lookalikes or normal flora, and, importantly, guide the right treatment.
What's step one in that lab process? Getting the sample.
Getting the right specimen. The type of sample collected depends entirely on where you suspect the infection is. The clinical picture guides the lab request.
Okay, walk us through the different samples mentioned in the source for these Neisseria infections.
For suspected meningococcal meningitis, the prime specimens are cerebrospinal fluid, CSF, from a spinal tap and blood, for blood cultures. These are best especially early on. Nasopharyngeal swabs can also be collected, maybe to find carriers or sometimes early in the illness, but CSF and blood are definitive for invasive disease.
And there was that crucial handling note for CSF.
Yes. Super important practical detail from the source. CSF, suspected of bacterial meningitis, should never be refrigerated. Why? Because if the infection happens to be caused by Haemophilus influenza, another major meningitis cause that shares some trace with Neisseria, those organisms can actually die in the cold. You get a false negative culture. Proper specimen handling is critical.
Wow, that's a potentially life-saving detail. Okay, what about samples for suspected gonorrhea?
For gonorrhea, it's usually sterile swabs from the suspected site. That could be the urethra in males, cervix in females, rectum conjunctiva for eye infections, or importantly for you, the oropharynx for suspected pharyngeal gonorrhea.
So swabbing the throat is key for that presentation.
Absolutely. You can also swab any purulent discharge directly. The source mentions using Stewart's transport medium for getting these swabs to the lab. That medium helps keep the bacteria alive without letting everything else overgrow during transit. Again, note that oropharyngeal site, that's a sample you might actually collect or see results from.
Once the sample gets to the lab, what's the first look? Microscopy.
Usually, yes. Gram staining is the first and fastest procedure. As we discussed, you're looking for those characteristic gram-negative diplicaci, often seen inside the PMNs, the white blood cells.
And how useful is that gram stain?
The source notes it's particularly useful for samples with a high bacterial load and relatively few other bacteria around, like male urethral exudate. Seeing those intracellular diplicaci there is a strong presumptive positive. However, and this is a huge caveat for interpreting results from oral samples, gram staining is significantly less reliable for specimens from the respiratory tract, and that absolutely includes the oropharynx.
Why is it less reliable for the mouth and throat? What's the problem?
The mouth and throat are just teeming with diverse normal flora. You've got all sorts of other bacteria, including various Streptococcus species, which are gram-positive cocci, but can sometimes look like diplicaci or stain weirdly. Trying to reliably pick out Neisseria diplicaci from that busy background, especially if they aren't numerous or clearly inside cells in that particular sample, it's really challenging.
So you could easily mistake something else or miss them.
Exactly. It can lead to false interpretations, both positive and negative. So the bottom line is, while you might see something suggestive, you absolutely cannot make a definitive diagnosis of oral gonorrhea based only on a gram stain from a throat swab. You need more.
That's a critical limitation to keep in mind for practice. Are there other microscopy methods that offer more specificity?
Yes. Fluorescent antibody, FA staining, is another technique mentioned. This uses antibodies tagged with a fluorescent dye that are specific for certain bacterial surface molecules, antigens.
So it's like using a glowing label to find the specific bug.
Pretty much. Direct fluorescent antibody, DFA tests, can detect specific gonococcal antigens in discharge, offering more specificity than just shape. For N. meningitis, FA staining can even identify the specific serogroup based on its capsule, which is useful for tracking outbreaks.
Okay, FA staining adds specificity. But for a definitive ID in antibiotic testing, you generally need to grow them. Culture.
Exactly. Culture is essential for getting enough pure bacteria to confirm the species and do things like antibiotic susceptibility testing. But, as we noted, Neisseria species are nutritionally fastidious. They're picky eaters.
Meaning they need special food to grow in the lab.
Yes, they won't grow on basic lab media. They need enriched media, like lice blood agar or, more commonly, chocolate agar. Chocolate agar isn't actual chocolate. It's blood agar that's been gently heated to release extra nutrients Neisseria needs.
Okay, chocolate agar. But even with that, if the sample's from the throat, won't all the other bacteria grow too?
That's the challenge. The normal flora from sites like the throat or genital tract would quickly overwhelm the more delicate Neisseria. That's where selective media come in.
Selective media, how do they select?
Media like Thayer-Martin medium are specifically designed for this. They contain the necessary nutrients like chocolate agar, plus a cocktail of antimicrobial agents, antibiotics, and sometimes an antifungal.
Ah, so the antibiotics kill off most of the normal flora?
Exactly. They inhibit the growth of most of the other bacteria and fungi that would otherwise take over the plate, allowing the Neisseria, which are resistant to those specific agents in the medium, to grow relatively undisturbed. Using selective media is absolutely crucial if you're trying to culture Neisseria or Kingella from a sample contaminated with normal flora, like from the mouth or throat.
That makes sense. Suppress the crowd to find the specific organism. What about the air they need in the incubator? Anything special there?
They're picky about that, too. Most pathogenic Neisseria strains are capnophilic.
Capnophilic.
Meaning they love carbon dioxide. They require an increased CO2 concentration, usually around 5–10%, for optimal growth. They also need high humidity and grow best aerobically at body temperature, 35–37 degrees C.
And the non-pathogenic ones?
Many of the non-pathogenic Neisseria are less demanding. They might grow on ordinary agar at room temp without extra CO2. So these different growth requirements can be another clue in the lab to help distinguish potential pathogens from their harmless relatives.
Okay, so let's say the lab managed to grow pure colonies using selective media and the right atmosphere. How do they confirm which Neisseria species it is?
Biochemical tests are key here. We already mentioned the oxidase test confirms it's likely Neisseria. They're all positive. But to tell N. gonorrhea from N. meningitis or other species, the classic approach is sugar fermentation tests.
Sugar fermentation? How does that work?
You basically see which sugars the bacterium can eat or metabolize. You inoculate the bacteria into different tubes or wells, each containing a specific sugar like glucose, maltose, sucrose, lactose, plus a pH indicator. If the bacterium ferments the sugar, it produces acid, and the acid changes the color of the indicator.
And the main pathogens have distinct patterns.
Yes, these patterns are definitive identifiers, according to the source. Neisseria gonorrhea ferments only glucose. Neisseria meningitis ferments both glucose and maltose. Other species have different patterns, like M. lactamica, a commensal, ferments glucose, maltose, and lactose, which helps distinguish it. These distinct sugar fermentation profiles are a standard, essential method for species identification.
That's a really neat way to tell them apart based on their metabolism. Are there any other, maybe faster tests?
Antigen detection tests can sometimes provide quicker results, especially for N. meningitis. These tests look for soluble bacterial antigens, like bits of the capsule, shed into body fluids like CSF. Rapid tests like latex agglutination, LAT, or co-agglutination can detect these antigens quickly. ELISAs, enzyme-linked immunosorbent assays, are also used for antigen detection.
And what about the really modern stuff, molecular diagnostics, DNA tests?
Absolutely. Molecular methods, especially nucleic acid amplification tests, or NADAS PCRs, the most famous type, are increasingly important and widely used. The source describes them as reliable, sensitive, and rapid.
How do they work?
They detect and amplify specific sequences of the bacterium's DNA or RNA directly from the patient sample. They're very common now for detecting N. gonorrhea in genitourinary samples because they're so sensitive, even if there aren't many bacteria present. While the source doesn't explicitly detail their use for oral Neisseria, the technology is certainly applicable and offers a highly sensitive way to detect these organisms.
Finally, sometimes labs look for the body's response, right? Antibodies.
That's serodiagnosis. Tests like ELISA can detect antibodies the patient has made against Neisseria antigens. They aren't usually the first choice for diagnosing an acute infection because it takes time for antibodies to develop, but they can be useful maybe in chronic cases, for tracking outbreaks, or if other tests were negative, but suspicion is still high.
Okay, so putting all these methods together, microscopy, culture, biochemicals, antigens, molecular serology, why is understanding this lab section so crucial for you, the dental student? Why wade through all this detail?
Because you will interact with this process. You might collect a sample, like that oropharyngeal swab. More often, you'll be receiving and interpreting lab reports. Understanding the nuances is vital for reading those reports correctly.
Like knowing the limitations of a gram stain from the throat.
Exactly. Knowing that seeing gram-negative diplococci on a throat gram stain is not definitive for gonorrhea, and that you need confirmation by selective culture and biochemicals, or maybe an edit, that's critical for making good clinical decisions and avoiding misdiagnosis. Knowing selective media was used tells you they specifically look for tricky bugs like Neisseria or Kingella. Understanding sugar fermentation lets you double-check the species ID on the report. It empowers you to understand the reliability, the limitations, and the complexity behind getting that definitive answer. It's truly foundational for evidence-based practice.
That's a fantastic point. The report isn't magic. Understanding the process behind it makes you a better clinician.
Okay, so the lab has identified the culprit. How do we treat these infections? Let's get into the challenge of treatment, because it's not always simple. You're right. Treatment relies heavily on antibiotics. But the landscape, especially for Neisseria infections, has gotten increasingly tricky.
And that trickiness comes down to one big problem mentioned in the source: antibiotic resistance.
Absolutely. The emergence and global spread of antibiotic-resistant strains, particularly Neisseria gonorrhea, is a major public health crisis. The source specifically flags two key types of resistance in N. gonorrhea. First, penicillinase-producing gonococci, or PPNG. These have a plasmid, little extra piece of DNA that carries the gene for that beta-lactamase enzyme we discussed.
The enzyme that chews up penicillin.
Right. And second, chromosomally mediated resistance, or CMRNG. This involves changes directly in the bacterium's main chromosome that affect how antibiotics get in, or how they bind to their target inside the cell.
How has this resistance impacted how we treat N. gonorrhea over the years?
It's completely changed the game. Decades ago, gonorrhea was reliably sensitive to penicillin. It was the standard treatment. But now, because resistance from both PPNG and CMRNG strains is so widespread, penicillin is generally not recommended anymore in most parts of the world. It just doesn't work often enough.
So what do we use now?
The source lists the current recommendations for uncomplicated gonorrhea, which often involve different classes of antibiotics like ceftriaxone, sulfixamide, ciprofloxacin, or afloxacin. It also notes erythromycin might be an option for kids or pregnant women. But this list is dynamic. Guidelines have to be constantly updated based on local resistance patterns.
We have to keep adapting as the bacteria evolve. What about treating Neisseria meningitis infections like meningitis? That must require strong treatment.
Yes, for serious meningococcal infections, especially meningitis, treatment usually involves high-dose antibiotics given parenterally, intravenously to make sure enough drug gets into the central nervous system. The source mentions antibiotics like cefotaxime and ceftriaxone are commonly used, often for a week or two.
Are other drugs effective?
Yes. Others mentioned include sulfonamides, chloramphenicol, and ciprofloxacin. An interesting aside the source makes is that some of these, like cefotaxime and ceftriaxone, are also effective against Haemophilus influenza type B, another big cause of bacterial meningitis. It's interesting because H. influenza also makes IgA1 protease and lives in the nausopharynx, showing some shared biology that influences treatment choices.
That's a neat link between pathogens based on shared traits and treatments. And what about Kingella kingae, that important oral commensal with the systemic links? Any specific treatment noted?
The source specifically notes that Kingella kingae is sensitive to tetracycline. That's useful clinical info. If you encountered a case where Kingella was identified, maybe a bone infection near the mouth or suspected endocarditis with an oral source, knowing its sensitivity helps guide antibiotic choice.
Looking at this whole section on treatment, especially the resistance issue and changing guidelines, what's the big picture takeaway?
The main thing is the relentless challenge of bacterial evolution and antibiotic resistance. It means we can never get complacent. We need ongoing surveillance of resistance patterns, and healthcare professionals absolutely must stay current with evidence-based treatment guidelines, which can vary by region and change over time. That mention of shared treatments for N. meningitis and H. influenza is also a subtle reminder that understanding the basic biology and virulence factors can sometimes hint at effective therapies, even across different types of bacteria.
So why is this section on treatment absolutely vital knowledge for you, the dental student?
Because you will be involved with antibiotics. You'll likely prescribe them for dental infections, or at the very least you'll be managing patients taking antibiotics for other reasons, maybe related to oral procedures or conditions. Understanding antibiotic resistance is fundamental to responsible antibiotic stewardship, using these precious drugs wisely to keep them working.
It's about being part of the solution, not the problem.
Exactly. Knowing that old standbys like penicillin might not work anymore for certain infections due to resistance is crucial clinical awareness. And knowing specific sensitivities like Kingella and tetracycline is directly practical information if you encounter infections involving this oral bug, especially those with potential systemic impact. It makes you more informed, responsible prescriber, and part of the larger healthcare effort to combat resistance.
Absolutely. Your role encompasses systemic health and medication management, not just teeth. Okay, let's bring all these threads together now. Let's really consolidate Neisseria's footprint in dentistry, those direct and crucial connections we've uncovered throughout this deep dive.
Okay, let's solidify this and make it explicitly relevant to your field. First off, we've established that many Neisseria species, the source mentioned, Ensiflava, M. mucosa, and Sicca, are just normal, common residents. They're found abundantly as commensals in the mouth, nose, pharynx, part of the healthy microbial ecosystem you'll be working in.
And they're not just sitting there passively. They actually play a role in that ecosystem.
They really do. The source highlights their ecological significance in the mouth. They're actually among the very first bacteria to colonize clean tooth surfaces after brushing or eruption. And importantly, they help shape the environment for other bacteria.
How do they do that?
They consume oxygen. By using up oxygen near the tooth surface, they lower the oxygen level, helping create the anaerobic or low oxygen conditions that are essential for the growth of many other bacteria, especially the strict anaerobes. These anaerobes are key players in developing mature plaque and in the pathogenesis of common oral diseases like periodontitis and some endodontic infections.
Wow, so even the good guy commensals help set the stage for potential problems later by changing the local environment. Fascinating. And we did reinforce that even these normal residents can sometimes cause harm.
Correct. While usually harmless, these commensal Neisseria can, under certain circumstances, switch roles and act as opportunistic pathogens. This risk goes up if the host's immune system is compromised, or if there's trauma or a break in the mucosal lining in the mouth or throat. The potential, though maybe low for most species, is always there.
Okay. Now for the most direct link of a typically pathogenic Neisseria to dental practice, Neisseria gonorrhea. Let's make that connection crystal clear.
This is a direct clinical relevance point. And gonorrhea can infect the oropharynx, usually through orogenital contact. When it sets up shop in the throat or mouth, it can cause symptoms that might bring a patient to your dental chair.
Like what symptoms specifically?
Pharyngitis, sore throat, tonsillitis, maybe even specific oral lesions or a type of gingivitis. If you see a patient with these signs and maybe something in their history raises suspicion, finding gram-negative intracellular diplococci on a smear could be a clue. However, and this is the absolutely critical point we stress from the source regarding diagnosis.
Don't jump to conclusions based on the gram stain alone from the mouth.
Exactly. Seeing that morphology in an oral or pharyngeal sample requires further testing, selective culture, and biochemical tests, or maybe a NAT to confirm it's definitely N. gonorrhea, and not just a harmless commensal Neisseria or some other look-alike bacterium. You cannot make that diagnosis based solely on a gram stain from that site. That need for confirmation is vital for accurate care.
That diagnostic nuance is incredibly important for avoiding mistakes in the oral environment. Now let's revisit Kingella kingae, which you highlighted as having particularly significant systemic connections starting from the mouth.
Yes, Kingella kingae, same family. It's an established member of the normal oral flora, and the source explicitly links it to serious systemic infections. Endocarditis and infections of bones, joints, and tendons.
And why is this such a big deal for dental professionals?
Because oral bacteria, including Kingella kingae, can get into the bloodstream during dental procedures, think extractions, deep scaling, periodontal surgery. This causes a temporary bacteremia. In people with certain heart conditions like damaged valves, this bacteremia can lead to infective endocarditis, a very serious heart infection. The link to bone and joint infections is also crucial. While the source didn't specifically blame it for jaw infections, it raises the flag that oral bacteria can potentially cause infections in adjacent bones or joints, fitting that broader context the source mentioned about anaerobes and other commensals in dental infections. Kingella is a prime example of a normal mouth bug with serious systemic potential.
So the presence of Kingella in the mouth really underscores that oral systemic health link and the importance of managing oral infections carefully, maybe considering antibiotic prophylaxis in high-risk patients. Finally, what's the practical day-to-day takeaway from all this microbiology for infection control in your future clinic?
It hammers home the absolute necessity of strict, universal infection control measures. Knowing that organisms like N. gonorrhea can cause oropharyngeal infections, even if uncommon, means you treat every patient as potentially infectious. Proper hand hygiene, gloves, masks, eye protection, meticulous instrument sterilization, surface disinfection, these are non-negotiable fundamentals.
And specimen collection.
If you are collecting an oral sample because you suspect Neisseria or something similar, knowing how to do it properly, minimizing contamination with normal flora, and ensuring it gets to the lab in the right medium, that's crucial for both getting an accurate diagnosis and protecting yourself and others. As the source concludes, a solid understanding of oral microbiology, including organisms like Neisseria and Kingella, isn't just about passing exams. It's truly foundational for providing safe, effective, and comprehensive dental care.
So this understanding really empowers you to recognize risks, understand how diseases work, interpret diagnostic tests correctly, and practice safely, ultimately connecting the dots between the microscopic world in the mouth and the overall health of your patients.
Precisely. It shifts the perspective from just treating teeth to being a healthcare professional who really grasps the broader implications of the oral environment.
Okay, we have covered a tremendous amount of ground in this deep dive. We started by identifying Neisseria at its core, those distinctive gram-negative coffee bean-shaped diplococci, and learned about their basic biochemical fingerprint, like the oxidase test.
We then explored their intricate morphology, focusing on that key intracellular location inside immune cells, and the protective polysaccharide capsule of N. meningitis, linking structure directly to how dangerous they can be.
We delved deep into their sophisticated arsenal of virulence factors, those variable pilities for sticking and dodging immunity, the inflammatory LOS endotoxin, the sneaky IgA1 protease disabling our mucosal defenses, the OPA proteins helping N. gonorrhea stick and even survive inside immune cells, and that antibiotic-destroying beta-lactamase. We saw how these tools let them cause disease and evade our defenses.
We then connected these tools to the actual diseases they cause, detailing the spectrum from gonorrhea, including its direct oral signs like pharyngitis, to the potentially devastating meningococcal infections. And we didn't forget the significant systemic links of related oral flora like Kingella kingae to serious conditions like endocarditis and bone or joint infections.
We navigated the complexities of lab diagnosis, understanding why you need specific specimens, the usefulness, but also the critical limitations of gram staining, especially from the mouth, the power of selective culture media like Thayer Martin, the precision of biochemical tests like sugar fermentation, and the growing role of modern molecular methods like NATs.
And finally, we grappled with that critical challenge of antibiotic resistance, understanding why treatments for things like gonorrhea have had to change so dramatically, and why knowing about resistance is so important for responsible prescribing and managing patients.
And all along the way, we've specifically focused on what this means for you as a dental student. Recognizing oral commensals versus potential pathogens, spotting clinical signs in the mouth, understanding those crucial systemic connections starting from oral bacteria, appreciating the nuances of oral sample diagnosis, and realizing that all this microbiology is absolutely foundational for safe practice, effective infection control, and truly comprehensive patient management in your future career.
Right. This deep dive, pulling directly from the source material you provided, aimed to cut through the noise and give you a clear, relevant picture of Neisseria and its implications for dentistry.
Knowledge applied is power, right. And for a dental student, this knowledge is directly applicable to patient health, safety, and your vital role within the healthcare system.
Couldn't agree more.
So as we wrap up this deep dive, here's a final thought for you to ponder, building on everything we've discussed today. Consider how that seemingly simple, identifiable coffee bean shape seen under a microscope hides such a complex, adaptable arsenal of molecular tools. Tools allowing some Neisseria to live harmlessly in our mouths while empowering others to cause devastating systemic disease. It reminds us just how dynamic, interconnected, and potentially surprising this microbial world we interact with daily truly is. What does this really underscore about the need for continuous learning, for vigilance, and for always seeing the mouth not in isolation, but as absolutely integral to the entire patient's health throughout your career?
That's a crucial perspective for any healthcare professional to maintain. Definitely something to think about.
That's it for this deep dive.